So with that, I would like to introduce our first speaker. We're very lucky today to have with us Dr. Kimberly Washington, who is an assistant professor in the Department of Surgery at Texas Christian University. She is a hepatobiliary surgeon and someone who is well-versed in a multitude of specialties in HPB surgery, both primary and secondary tumors. And today, she's going to be discussing with us the epidemiology, incidence, as well as geographic and overall risk factors associated with this disease. So with that, again, I'd like to welcome Dr. Washington, and I will turn the screen over to her. Kimberly.
The epidemiology risk factors, and I'll highlight a little bit of the disparities that are seen in mostly the United States, but I'm sure some of those factors can be kind of similar around the world, mainly due to the differences in socioeconomic standards and factors worldwide. So we often discuss statistics and epidemiology of a disease process, and it can't be overstated how important this practice is, particularly in rare diseases like intrahepatic cholangiocarcinoma. The intent of epidemiology is to prevent or reverse negative health outcomes. And I hope to show in the next 15 minutes a sweeping overview of intrahepatic cholangiocarcinoma and how our study of incidence of disease and impact can improve outcomes, particularly for those in lower socioeconomic status. Intrahepatic cholangiocarcinoma is rare, accounting for about 3% of gastrointestinal malignancies worldwide. It comprises about 15% of all primary liver cancers, second only to hepatocellular carcinoma. Intrahepatic cholangio is infrequent in patients younger than 40 years old and has a peak incidence between the 5th and 7th decades of life. Most recently, it's been thought that the increasing incidence is truly an increase and not a function of earlier detection, since the increased incidence is independent of tumor size or stage. So there's a huge discrepancy in worldwide rates of intrahepatic cholangiocarcinoma, with higher rates in Eastern Asian countries compared to Western countries. The intrahepatic cholangiocarcinoma rates vary from as high as 96 per 100,000 in men and 38 per 100,000 in women in Northern Thailand, to as low as 0.2 and 0.1 per 100,000 men and women in Australia. So a very, very significant difference in numbers as you move from country to country. As many of you know, this disease is often asymptomatic in the early stages and thereby makes it harder to treat. For those detected through screening and who present with early stage disease, cirrhosis is not only a common etiologic factor, but a condition that can complicate or limit the available treatment options. Therefore, the best opportunities for improving the care of these patients are either through prevention of underlying liver disease or identification of at-risk patients, ensuring that they're appropriately screened for the development of primary liver cancer. This highlights just how little is known about the epidemiology of intrahepatic cholangiocarcinoma, particularly in Western countries. Many ICCs are detected during hepatocellular carcinoma screening in at-risk patients or those who are undergoing treatment for presumed diagnosis of hepatocellular carcinoma. And as such, many of the commonly cited HCC risk factors are shared by ICC. Therefore, it's believed that inflammation and subsequent injury to the bile ducts plays a role in carcinogenesis. So just looking at a few of the risk factors for intrahepatic cholangiocarcinoma, and again, this may sound somewhat like a broken record for HCC, but as stated before, the reasons are they tend to be found in patients who are being screened. Cirrhosis has a 10 to 20-fold increase in intrahepatic cholangiocarcinoma. Viral hepatitis, including Hep B and Hep C, provide about a 2-fold increase in intrahepatic cholangiocarcinoma risk. And although there are very few studies that assess the association between alcohol use and intrahepatic cholangiocarcinoma, there is a weak association between the development of cirrhotic liver disease in the context of alcohol use and cholangiocarcinoma. Tobacco use as well. There's meta-analysis of case control studies that shows smoking has a non-significant 31% increase in odds of intrahepatic cholangiocarcinoma. But there was also, in comparison, a population-based study where smoking was associated with a statistically significant 80% increase in odds of intrahepatic cholangiocarcinoma. So smoking, as everyone knows, has been one of those factors that we found in association with almost every malignancy. So of course, intrahepatic cholangiocarcinoma would be no different. There's a SEER registry data as far as in relation to diabetes that suggests a greater than 50% increase in likelihood of cholangiocarcinoma in patients with diabetes. It's unclear if diabetes results in liver damage, which causes non-alcoholic fatty liver disease, or if diabetes itself increases the risk above and beyond that associated with chronic liver disease. That's an important unanswered question that we probably should study a bit more. Obesity, again, a meta-analysis in US population-based cohort identified overweight and obesity being associated with 56 to 70% increase in risk of intrahepatic cholangiocarcinoma. Interestingly enough, a Danish study didn't find a similar correlation. So there's much more that needs to be done in order to determine whether obesity is truly a risk factor. Of course, choledochal cysts, we're very familiar. These tend to cause more extrahepatic cholangiocarcinomas, but can also develop intrahepatic as well, particularly in the type 4 and type 5 choledochal cysts. Similarly, primary sclerosing cholangitis, 7 to 15% of those patients will develop intrahepatic cholangiocarcinoma. And hepatolithiasis, the process by which that develops, that causes ICC, is thought to be related to bile stasis, which leads to bacterial infection and chronic inflammation. Of course, we can't avoid discussing parasitic infections, particularly in Korea and Thailand. They afford a 2 to 5% increased risk. And just for historical significance, Storatrast was a contrast agent that was banned about 50 years ago, but exposure to it led to a 300-fold increase risk of developing ICC. There are a couple of things that have been studied to decrease risk of ICC. One, in a population-based study, they identified patients who were diabetics who were treated with metformin, noted a lower risk. This has only been in one study, so more information is necessary there. And of course, aspirin, because of its anti-inflammatory effects, has been thought to potentially have an effect on decreasing all malignancies that are related to inflammatory states. And the Liver Cancer Pooling Project suggested that aspirin use lowered the risk 36% in men, but no significant difference in women. So there's more to learn when it comes to the epidemiology and the risk factors associated with intrahepatic cholangiocarcinoma. And now moving on, the last few slides to healthcare disparities, particularly for this disease, and this is catching on for many malignant states. The SEER database studies have identified higher incidence rate of ICC in, as well as poor survival in men and older individuals. Additionally, in the US-based studies, they've also identified in a couple of different database studies the higher incidence of intrahepatic cholangiocarcinoma in Caucasian Americans compared to African Americans. However, their all-cause mortality is similar between the two groups, which is interesting. Additionally, we should learn more about the impact that age, for example, race, ethnicity has on ICC, as well as the risk factors and strategies to effectively prevent this disease. And one example to highlight the importance of paying attention to the differences that are seen in various disease processes is that in patients with ICC, we know that it typically happens in older age groups. So Analysis of the impact of age on incidence and survival is necessary to determine whether risk factors for intrahepatic cholangiocarcinoma in younger individuals differ from those in older individuals. And that's one way we can use that data to learn more about this disease process. This slide, this is actually a study that reviewed about 11,000 patients with histologically confirmed intrahepatic cholangiocarcinoma between 1995 and 2014. And they found that age-adjusted incidence rates were higher for males and females, the higher for Asian and Pacific Islanders than Caucasians, and that Hispanic ethnicity afforded a higher incidence of intrahepatic cholangiocarcinoma compared to non-Hispanics. And just looking a little bit more detailed at this particular chart, this looks at the 1 year and 5 year. This is disease-specific mortality. And it shows that particularly in American and African Americans, their disease-specific mortality is higher at 1 and 5 years, and similar for Hispanic Americans. And so this is something obviously that we need to hone down a little bit on. These are the Kaplan-Meier survival curves, again, showing a poor 5 year overall survival and disease-specific survival in individuals over the age of 45 compared to those under 45, as well as poor outcomes in Hispanics compared to non-Hispanics. And lastly, this study I found very interesting in that it reviewed a total of 100,000 patients who were admitted with a diagnosis of intrahepatic cholangiocarcinoma, of which only 7,000 subsequently underwent an operation, which represents about 7% of that population. And their study identified that patients who were younger were more likely to undergo an operation. Those who were Caucasian American were more likely to undergo an operation. Those who had private insurance, so a payer source, were more likely, as well as those who had a lower comorbidity index, which I'm sure that comorbidity index correlated well with age. And so just figuring out ways to understand better this data, I think is very important. So lastly, because the incidence of intrahepatic cholangiocarcinoma is increasing worldwide, including in the United States, it's important that we identify the needs that we have in this particular disease as far as epidemiologically. Since it's rare, we need comprehensive population-based studies that assess risk factors and determine if mitigation techniques exist and if we can implement them. We also need robust data analyzing socioeconomic factors and their impact on diagnosis, treatment, and survival. We'll stop sharing here.